How's it going, everyone? Today we will be finishing up our discussion on the arterial system. We'll be talking more about mean arterial pressure and blood flow and resistances throughout the arterial system. Let me start by reintroducing the primary regulated variable of our cardiovascular system, and that is mean arterial pressure, or the average pressure in our arteries during one cardiac cycle. Now, we know that the relationship between pressure and flow and resistance can be quantified in this hydraulic resistance equation, where pressure is equal to flow times resistance. And so if we equate that to mean arterial pressure, that the average pressure in the arteries is going to equal cardiac output, which determines blood flow, times the total peripheral resistance. And so when we say the primary regulated variable, that means in order to keep up with mean arterial pressure, which is what our cardiovascular system in the brain is constantly monitoring, that in order to deal with changes in mean arterial pressure, the body will adjust cardiac output and total peripheral resistance in order to maintain that set pressure. Now, if you want to actually quantify mean arterial pressure, you could use this equation right here, which is equal to diastolic blood pressure plus 1/3 of pulse pressure. And pulse pressure is systolic pressure minus diastolic pressure. So let's say we take the average and most popular known blood pressure of 120/80. And so we take that 80 and then add 1/3 of pulse pressure. So if we had 120 minus 80, that would be 40 for pulse pressure. 1/3 of that, you're looking at 13.3333 repeating here. So ultimately, when you add 80 to 13.33, you would get a mean arterial pressure of 93.3. We have different receptors called baroreceptors, which are going to pick up on changes of arterial pressure in the aorta and the carotid arteries. And so if there is a change that occurs in our cardiovascular system and mean arterial pressure is affected, well, then ultimately we are going to either have to change cardiac output or total peripheral resistance, or both, in order to correct that change. And so if the heart, however, is in a compromised position, let's say we are standing upright and there was a decrease in mean arterial pressure, well, that is going to limit the amount of work that the heart can do in order to restore mean arterial pressure. Because remember, when we're in upright posture, a lot of our blood, or most of our blood, is going to be pulled below the heart, and that's going to limit the venous return, which then limits the stroke volume and the cardiac output. So that's going to be a little bit compromised as far as its ability to regulate mean arterial pressure. So in that case, an increase in total peripheral resistance is used in order to restore mean arterial pressure. And how do you increase total peripheral resistance? Well, you increase vasoconstriction, which decreases the radius of the arterioles and thus helps to bring up mean arterial pressure. When we are looking at the different pressures within a blood vessel, there are 3 different types. We have static pressure, which is related to the volume of blood within the vasculature at zero flow, so no blood is flowing. So typically it's going to be around 7 mmHg in dogs and is thought to be similar in humans. So the static pressure is just basically the pressure of the blood itself, right? The more blood you have, the more pressure it's going to put against the walls of those blood vessels. And so again, that pressure just by the blood itself, static pressure. Hydrostatic pressure is going to be due to differences in the height of a column of fluid. And we talked about it before, but remember the equation for hydrostatic pressure is the density of the blood times gravity, which is a constant here on Earth, times the height of the column of fluid, or in our case, blood. So again, we talked about this, and we talked about sort of simplifying this equation, since gravity is going to be a constant here on Earth anyway, and the density of the blood from minute to minute really isn't going to change. So we said that really the hydrostatic pressure is going to be proportional to the height of the column of the blood. And we use the reference point of our heart to determine this. So if we're looking at hydrostatic pressure while we're lying down, well, the height differences between our heart and our feet and our head and most of our body are going to be pretty small. So hydrostatic pressure isn't really going to vary too much across the body while we are lying down. However, we stand up, and then gravity is going to pull that blood towards the lower limbs, towards the feet. And so, just as if you were to have multiple things stacked up on top of each other, most of the pressure is going to be felt there at the bottom, at the foundation. And so, similar to when we stand upright, we're going to have the greatest pressure the furthest distance away from the heart. So again, hydrostatic pressure, when it comes to us and overall pressure, is going to be dictated by our posture and basically where in the body in reference to the heart that we are talking about. Then we have dynamic pressure, which is the pressure generated from the heart and what helps to yield the hydraulic resistance equation, which again, pressure is going to be equal to blood flow times total peripheral resistance. And again, that blood flow, that stems from the dynamic pressure produced by the heart, or the cardiac output. So ultimately, if you ask the question, what impacts blood pressure? Well, it's going to be either the volume of blood, our posture, or the phase of the heart, which takes us into what are the determinants of mean arterial pressure? Well, we have physiological factors, and then we have physical factors. And so cardiac output and peripheral resistance are part of that equation, which determines mean arterial pressure. So ultimately, changes in heart rate, stroke volume, and then blood vessel radius, blood vessel length, blood viscosity are ultimately going to impact the arterial blood volume, right? And that's going to bring about changes in arterial blood pressure. But then we also have the arterial compliance, and we sort of talked about in the last lecture how that also can impact flow and pressures within the arteries. And so when you look at mean arterial pressure overall, there are a lot of different factors that ultimately will impact mean arterial pressure. And so again, branching off from cardiac output into total peripheral resistance, we have heart rate and stroke volume on the cardiac side. And as we discussed, that can be impacted by venous return or contractility or blood volume, even the autonomic tone of our nervous system, whether the sympathetic or parasympathetic division is more dominant. And then on the vasculature side, blood vessel radius, blood viscosity, and blood vessel length ultimately can determine TPR, which again is brought about by sometimes changes in autonomic activity, and then, less so. Again, we talked about how blood vessel radius is more so the determinant, but, the number of erythrocytes compared to the plasma, and then blood vessel length. But, when we say the primary regulated variable, mean arterial pressure, well, what does that mean? Well, ultimately, our body and our brains are concerned with keeping this constant, right? So as you sit here right now, your brain has a set point for mean arterial pressure. And so if changes are brought about, what your brain and your nervous system wants to do is correct those changes as quickly as possible. And so it will ultimately bring about changes in all of these different factors, which ultimately are going to impact cardiac output and total peripheral resistance in order to stabilize and maintain your mean arterial pressure. Now, looking at the determinants of mean arterial pressure, first, let's focus on the heart and its effect on mean arterial pressure. And so, ultimately, that pressure within the arteries is going to be due to the amount of blood that is entering the arteries, and the amount of blood that is leaving the arteries. So, the amount of blood entering the arteries is going to be due to the flow of the heart or cardiac output. And the amount that's leaving is going to be due to that arterial runoff, or how much is going from the arterial side from the arteries to the arterioles. And so that's going to be determined ultimately by resistance. Again, let's just focus on the heart right now. Focus on that QH, or that cardiac output, and its effects on the arterial pressure. If we increase that cardiac output from the heart, well, where is that blood going to go? Well, since the arteries are by nature pretty compliant, those large arteries are compliant and can hold on to blood, since this initially, the flow of the heart is going to exceed that arterial runoff, well, that extra blood ultimately winds up in the arteries. And what's going to happen is that since there is an increase in arterial blood volume, well, then the pressures within that artery are going to start to increase. And then ultimately what's going to happen is that mean arterial pressure will increase for as long as the output of the heart is exceeding that arterial runoff, or the amount that's going and flowing through to the arterioles. Ultimately, the mean arterial pressure is going to hit a peak at 200 mmHg, and then we will start to see the runoff equal that increased flow of the heart. And so ultimately, when there is that increase in cardiac output, we are going to get an increase in pressure, but then what's going to happen is that extra buildup, that extra pressure that is developed within the arteries is going to force an increase in flow through to the arterioles. We are going to see mean arterial pressure increase as cardiac output increases. The initial increase is fairly rapid, but slows down once that sort of equilibrium between the output of the heart and then the runoff to the arterioles reaches equilibrium. Now, as far as the rate is concerned, this is going to be dependent upon the compliance of the arteries. And so if you look at more rigid, less compliant arteries, you're going to see that rate and that pressure dramatically increase. It's going to increase a lot quicker than if you had more compliant arteries, right? But again, note that I said rate, which is the amount of time. The magnitude is not going to differ based on the compliance of the artery. So ultimately, if there's that increase in cardiac output, mean arterial pressure is going to increase no matter what the compliance of the arteries are. But again, if your arteries are more compliant, then just the rate of it is a little bit less, and those pressure differences will increase a little bit slower as compared to less compliant arteries. Ultimately, the pressure is going to rise to a level where the output of the heart is then going to equal of the flow, and then this will help to increase and sort of catch up on those differences, and blood will continue to flow. That increase in blood flow will then translate through the rest of the arterial circulation. So that showed us how differences in the heart, in the output of the heart, can impact mean arterial pressure. Obviously, the more output that the heart is producing, the more flow that is producing. If that is not matched by an outflow on the back end, well, then that pressure is going to build up inside. But then, we have resistance as well. So let's talk about that branch. So if we kept cardiac output the same, but we increased resistance, which remember, mainly we talk about blood vessel radius. So if we look at A here, which is our control, and compare it to D, where there is less radius, where there is less space for that blood to travel, well, then resistance increases. And so now that ultimately is going to, again, impact that runoff, that QR in our case, right? And so again, we get the same issue, that the output of the heart is greater than the flow heading to the arterioles. And so if we are having more blood that is basically backed up due to this increase in resistance, well, what occurs? We get that increase in pressure again. So, ultimately the same product, a increase in arterial blood volume, which increases arterial blood pressure. And it can be brought about, again, by either increases in cardiac output or increases in resistance. But ultimately, the end is the same, where we are going to have an increase in blood volume and then an increase in blood pressure. But then as that, pressure starts to increase, due to the nature between flow and pressure and resistance, then what's going to happen is that that pressure is going to start to overcome that resistance, and then there will be that equilibrium between the output of the heart, the flow of the heart, and then the flow to the arterioles. Let's break down cardiac output a little bit further and talk about the changes that occur to mean arterial pressure due to increases in stroke volume. So when we say an increase in stroke volume, that means that more blood is leaving the left ventricle during contraction. And an increase in stroke volume will then mean that more blood is leaving the left ventricle and entering the arteries. So that's going to increase arterial blood volume, which then in turn increases arterial blood pressure or mean arterial pressure. And so let's break that down a little bit further and talk about the differences that occur between systolic and diastolic pressures when we have that increase in stroke volume. So here on the figure, you could see A is going to be a, let's say, control stroke volume, a lower stroke volume, and then B is going to be when stroke volume doubles. So what is occurring to pressure and volumes when we increase stroke volume? Well, diastolic here on our control is going to be P1, and that pressure will produce a certain amount of arterial blood volume. And then during systole, A2, obviously that pressure is increased and that blood volume is increased. And if you take the differences between A2 and A1, or really P2 and P1, you get pulse pressure, right? And then, that ultimately those pressures are going to translate to an amount of arterial blood. But now we increase stroke volume, right? So we're going from P1 to P3 during diastole, and then from P2 to P4 during systole. And so by increasing stroke volume, what we see is that the increase in systolic blood pressure, P4 minus P2, is greater than the increase in diastolic pressure from P3 to P1. And overall, what this is going to lead to is that if you have a greater systolic pressure rise than a diastolic pressure rise, well, ultimately, your pulse pressure is going to increase more than really mean arterial pressure when stroke volume increases. And so you could see that by the differences between P4 and P3. This all right here, that's going to be your pulse pressure, is much larger than the pulse pressure here during your control. So ultimately, an increase in stroke volume is going to increase systolic blood pressure, but overall there will be an increase in mean arterial pressure because more blood is leaving the heart, and that will translate to a higher arterial blood volume, which increases mean arterial pressure. Now, we have arteries that stem from all over and deliver blood to all these different areas of the body. And so ultimately, you're going to get a pressure wave that is generated by that left ventricular contraction, which travels a little bit faster than the actual flow of blood. And so when you're actually taking and palpating for someone's pulse, what you're detecting is changes in pressure, not necessarily changes in flow. And so if you compare these different areas of the body, what you are going to see is different differences in pressure across the body. And we talked about, again, earlier what can determine these differences in pressure. And so when we look at these pressure waves, the velocity of that pressure wave, right? That's, you know, the total amount over time. So we have to pretend like this is a graph here with both x-axes and y-axes, and time would be down here at the bottom. So that velocity of the pressure wave is inversely related to compliance, meaning that if you have a higher compliance, there is a slower pulse wave velocity, or PWV, which is formed. And so if we then compare the different areas of the body, we could see that that velocity is the slowest here right in the aorta. And if you take sort of the bottom of the wave and the top of the wave, it takes a lot longer, or I guess relatively, it takes longer for the arterial arch here, sorry, the aortic arch here, to have its peak in that pressure. And so that shows that there is a higher compliance in the aortic arch than compared to the distal arteries. And again, we could see that by an increase in pulse wave velocity as you move further away from the heart. Due to the elastic nature of the arteries, some of that energy in the forward propagating pressure is actually going to be reflected back towards the heart. And that is shown as a backward reflective wave. And what we see is that, again, arterial compliance is going to determine the speed or velocity of this reflective wave. And what we see is that when we have an increase in arterial stiffness or a decrease in arterial compliance, the faster the velocity of that reflective wave. As we discussed in the first lecture of the arterial system, as we age, our arteries become less compliant. And so when we look at pulse wave velocity, this is going to increase, just as we discussed on the last slide. So as you compare an older individual with a younger individual, again, we see this pulse wave velocity increase, letting us know that there are less compliant vessels in older individuals. And so that wave is transmitted faster. And so, you know, we can use this pulse wave velocity in order to get an index and a sense of our vascular health. If we look at differences in pulse pressure down the arterial tree, we could see that, you know, let's use this 24-year-old here. If you look at the difference in systolic pressure and diastolic pressure in the aorta versus the systolic and diastolic pressure in the femoral artery, there is a much greater pulse pressure in the femoral artery away from the heart than it is closer to the heart. When comparing age, you could see that towards when it's closer to the heart, there are these distinct differences between pulse pressure and the amplitude and sort of the contour of these waves as we age. But then as you get towards further away from the heart, those pulse pressure differences are sort of minimal down the arterial tree. But what we see really is that, you know, these waves, when you compare them throughout an older individual, the changes are going to be relatively minimal because that reflective wave in older individuals with stiffer arteries, less compliant arteries, is superimposed earlier in time. So again, you see a little bit of difference there as far as that reflective wave and how the wave looks overall. Comparing the arterial tree, more distinct differences in that younger individual than the older individual, again, because of that reflective wave, which is superimposed on top of that pulse pressure wave earlier in time. That concludes our discussion on the arterial circulation. We talked all about mean arterial pressure and the different determinants of mean arterial pressure. And then again, we talked a little bit more about arterial compliance and what role that plays in the differences between systolic and diastolic pressure. throughout the arterial circulation and as we age. Thank you guys so much, and I'll see you in the next video.